Yeah, I think that's
Hello?
that looks like Anneliese.
Yep.
Oh, so
Yes. Hello?
I think there's someone two cameras going. I mean, two computers going.
Okay.
Hi.
Hello.
It's not easy with the techniques, so we hope we will achieve that.
Should we stand behind you like this?
Yes. And sorry.
one issue, Anneliese, is that we can't share the screen.
Sorry, the screen. Yes. Okay, so I need to sit here to be on the screen. That's it. But I will.
Andy just said he can't share the screen, but I think Andy just said that he can't share the screen.
Be right back. I'm just going to grab
Yes,
water.
it's better, Andy, if you share your screen after. Yes.
Anneliese, I can't share my screen. It won't let me.
You can't.
No, because
No, none of us can.
the icon says only presenters and meeting organizers can share, and it looks like we're not presenters. I don't know why.
Okay. And you, Sapna? It's the
I
same?
can't either.
Okay.
None of us can.
You told us we had to change our names, but we don't know how to do that.
Okay. Sorry?
Andy, you just go to the top right of Zoom and
Yeah.
it says rename usually.
We're not on Zoom, we're on Teams.
Oh, on Teams. Okay. Is there somewhere where you can look under more at the top? There should be somewhere where you can rename. But we can see your names. They're fine, I think.
Oh,
Okay.
can you?
Yeah, but we can't share the screen. That's the problem. We don't know whether it's because we're wrongly named or...
I'm just about to ask them to change you to presenters. One sec.
Ah, okay. Hello, Gail.
Good morning, Andrew. Good morning, everyone. It took me a while to even connect. I don't know why.
Oh, well, you're here. That's good.
Yeah.
Might
So
open up the window.
are we advancing our own slides and
We
or how's
don't
that
have
going?
the capacity to share yet, but I
No,
believe somebody is looking into that so that we can.
Okay.
So TBD.
Yeah, Anneliese is trying to get us made presenters, but at the moment we're not presenters.
Tu veux que je récupère les PDF et que tu montes sur mon écran?
Les PDF, je les ai là.
Ben, on va essayer d'essayer, sinon on leur dit.
Ouais.
The alternative solution would be for us to show your slides, but then you would need to tell us when to change.
Yeah, well,
I think for
okay.
you, Andrew, we have a PowerPoint. For colleagues from California, we only have a PDF, so I hope there won't be anything funny about it, but we can just try that.
Anneliese, I sent my slides to you this morning.
Yeah, but I think it's a PDF.
No, I sent it in a
Yes.
power.
I have for you, Sheri, yes.
Okay.
But for Sapna and legal, I have only the PDF.
That's
Okay.
right. I had to send PDFs because the email servers were not accepting the large files.
Right. Same here. But Sheri, you were able to send yours?
Mm-hmm.
Should I try sending again to Anneliese?
You can.
What time do we start?
1 minute ago.
Oh.
Looks like we can share now.
Oh. Oh, I can't.
It says it's come alive. It says you're a presenter. So shall I try it? Do you want me to try it now?
Yes.
Yes, Andy, you've been upgraded to presenter, all of you, so you should be able to share yourself.
Okay.
Is that showing?
presenting. Now I'm trying to get out of presenting.
Is that showing up, my slides?
No, it's not.
Okay.
Can you see my slide?
Yes, we can see your slides, Gail.
But we see your notes, so you may want to do it in the slide.
Oh, right. Okay. Let me try it.
Maybe it's because Gail's sharing hers. Yeah.
Let me go ahead and try. There we go. Is that better?
No, we see, oh yeah, there we go.
Yeah, we see that.
Okay. Good. Okay. Let me turn it off and someone else can try sharing.
Shall I try mine now?
Yes.
Please.
Yes.
Wow, it doesn't give, strange, it doesn't actually give my presentation.
I think in order for you to be able to show, the other presentation needs to be closed.
Yeah.
Oh, you have to close yours. You have to
Okay.
unshare.
I thought I did. Okay. There we go. Okay.
Okay, let me try now. How about that? Is that showing?
No.
No.
That's really weird.
All right, so since we're running a bit late, I propose that Andrew, we will be showing your slides from here. You can just ask us to pass. So whenever you're ready, you just tell us and we'll do this. And then we will start with the opening statement by Anneliese. And so we'll tell you, colleagues in California, when to upload your slides. All right? Good.
Okay.
Wonderful.
Perfect,
And
thank you.
Sapna, you can load mine for me because it wasn't working for me.
Okay.
All right.
Moi, je veux pas des slides très importants. Ah, bah sinon, tu vas là-bas. Oui, tiens, là. Daryl, thank you all very much for attending our event tonight. I'm really happy to see the growing interest for health-related issues in the climate community. This side event is jointly organized by the Center for Climate, Health and Equity at the University of California and the Centre Virchow-Villermé at the University Paris-Cité. My colleague Sapna Thottathil will introduce the former in a few minutes, and I would like to say a few words about the latter. So my name is Anneliese Depoux, and I'm the director of the Centre Virchow-Villermé in Paris, a joint research center in public health established jointly between the University Paris-Cité in Paris and Charity in Berlin. Most of the work we do relate to the health impacts of climate change, and we aim to become a key hub for research and education in the field in Europe. Even so, these health impacts are increasingly documented by scientific panels, such as the IPCC or the Lancet Countdown on Climate Change. There are still many blind spots when we look at the interactions between health and climate change. And these different blind spots also represent further avenues for cooperation between the health community and the climate community. One of these blind spots is the role that health factors can play in the decision to adopt individual behavior that reduce the carbon footprint. For example, many people who ride a bike to work or eat a vegetarian diet do so to improve their health rather than reduce their greenhouse emissions. again, the COVID-29 pandemic showed us the importance of health concerns for people and governments to make radical changes. It is my opinion that we should use these to our advantage and activate these levers. Another blind spot is the role of hospitals and medical schools in this. The health sector is a significant contributor to climate change, and yet this remains little known. Globally, it is responsible for 5% of total greenhouse gas emissions, with hospitals being particularly energy and resource intensive. Healthcare systems in Western countries are responsible for up to 10% of all CO2 emissions. This is huge, and it means the health sector also has to reduce its greenhouse gas emissions. For this purpose, there are a variety of mitigation measures that can be implemented in hospitals, but not only. And some of these measures include financial and health benefits. Healthcare must respond to the growing climate emergency, not only by treating those who are physically or mentally affected by the impacts of climate change. It also needs to practice primary prevention and radically reduce its own emissions. Several health systems in multiple countries are already leading the way and can serve as models for the sector. Ambitious plans are moving fast in some countries, such as the UK, to achieve zero net emissions by 2040-45 for the National Health Service. Internationally, the Alliance for Planetary Health in France, which I am representing today, gathers about 100 of health professionals, practitioners, and decision makers engaged on these issues. Our event today seeks to shed light on the different ways hospitals and medical schools address climate change. We shall address how hospitals can act and ensure institutions in their communities to lead on climate action. Speakers will focus on policies, decarbonization practices, and research priorities implemented by hospitals and universities that can help drive upstream carbon reduction and improve the resilience of vulnerable communities. For this, we have partnered with some excellent friends and colleagues from the London School of Hygiene and Tropical Medicine, Sciences Po, the Heidelberg Institute of Global Health, the Maldives National University, and Alliance Santé Planétaire. We are lucky to benefit from the support of the Horizon 2020 program, Kiwitas Sun Plus project, and the Erasmus Plus program Children. The event is also supported by the ANR and the state under the program Investissement d'Avenir in the framework of the IDEX, Université Paris-Cité Politique de la Terre. Beyond this, I would really thank the Faculty of Health of the Université Paris-Cité, as well as the Centre for Politique of Earth, for their essential work on the climate health nexus with regard to both research and education. The training of doctors plays a critical role in the decarbonization of the sector. Finally, I would like to introduce the fantastic lineup of speakers who will be talking today. Some are here with us on the podium and others are connected online. So first, Sir Andy Haines, professor at the London School of Hygiene and Tropical Medicine, will introduce the issue of decarbonization of the healthcare sector. Gail from the University of California will speak about the operational actions and policy decisions the University of California is making in its health systems. Gail will provide specific examples around electrification, anesthesia gas reduction, and MRI energy efficiency. Sheri Weiser, also from the University of California, will speak about the research priorities in the new University of California Center for Climate, Health, and Equity, including the impacts of wildfire, smoke, and heat distress on vulnerable populations. Trish Nanya Schwertler from Heidelberg Center of Environment, Heidelberg University, will talk about how climate resilient and environmentally sustainable health facility frameworks can be applied to developing countries, fragile and conflict-affected states. Charlotte Halpern, who is here with us, is based at Sciences Po, will speak about the green plan by the NHS. Finally, Rainer Sauerborn from Heidelberg University is also at the COP and will join us just in a few minutes. I will present the CLEAR project about climate change mitigation in hospitals by optimizing supply chain. Thank you, Sapna. I will give you the floor. Thank you.
Thank you, Anneliese. Can you hear me?
Yes, very well.
Okay, I'm going to share my screen. Hopefully it will work. Okay. Can you all see my screen?
Yes.
Okay, thank you. Okay, good evening, everyone. My name is Sapna Thottathil. I am the Managing Director for the new Center for Climate, Health, and Equity at the University of California. And I am truly sorry that I can't be there with you all in person today. The University of California is one of the co-hosts of today's session, and I will introduce our other University of California speakers again briefly at the end. So thank you all for joining, and I hope that we will all have a chance to be together in the room someday, especially as we all have to work on mitigating climate change together as a community. Thank you, Anneliese, for managing the logistics on the ground and Université Paris Cité. So like Anneliese, I wanted to provide some context for the specific focus on health and set the stage for our speakers. I especially want to describe what's going on in California, since there are a few of us from California. So as you all know, climate change is an unparalleled threat to human health. The Lancet, the most prominent global medical journal, just recently came out with a report that indicated that globally, a growing number of mortalities, increased infectious disease transmission, increased emergency room admittances, worsened mental health outcomes, and hunger can be attributed to rising temperatures, wildfires, extreme and sudden weather events, droughts, and crop failures, all because of climate change. Communities in California already suffer many climate health effects, from heat strokes during our unprecedented heat waves to psychological trauma after wildfires. We also know, this has been documented, that hospital visits have increased as a result of our state's massive wildfires and heat waves in the past few years. Ironically, and as Anneliese pointed out, as climate change poses a strain on hospitals and clinics, the healthcare sector contributes to a significant portion of emissions globally. I've seen some estimates that say 4.4 to 4.6%, and the U.S. has an outsized impact from that, being responsible for a quarter of those emissions, as some estimates show. Health systems need to be prepared to aid populations as the impacts of climate change will worsen, and also be prepared to mitigate their own climate impact. So in response to these concerns about health and climate, the University of California is taking action. So a little bit about the University of California. We were established in 1869, and we are a public university with 10 campuses, 6 academic medical centers, 12 hospitals, and 3 national laboratories. We employ and serve 227,000 employees and over 280,000 students. The university supports 1 in 45 jobs in the state, and the annual economic impact of our activities including research into clean energy, medicine, and science and technology, is $82 billion. We've had robust sustainability goals for years, and we have been working on tackling climate change for years. Here's a brief timeline here on the screen. So in 2003, we made a formal commitment to sustainability, and in 2013, our university system made a commitment to carbon neutrality by 2025, which was very innovative back in 2013. To meet that commitment, we have done things like form our own internal power company. It is now carbon neutral and currently supplies 40% of our purchased electricity. We've invested in energy efficiency, green buildings, etc. And you can read more if you click on the link or scan your phone and take a look at the picture of this code at sustainabilityreport.ucop.edu. And in 2022, we launched a Center for Climate Health and Equity that focuses on this nexus of climate and health. So I will stop there, and I'll leave it up to my colleagues to share more details about what the University of California is doing in both healthcare operations and research, from best practices and innovative actions to challenges. Anneliese, I believe is it Gail that's going next? I want to confirm with you.
No, Handy will now have the floor.
Okay. I will stop sharing. As soon as I can figure out how. My apologies, I'm having a hard time figuring out how to stop sharing. If anyone has a tip that they can share, I would appreciate it.
If you go to the share icon at the top of your screen, does that allow you?
I'm clicking on that. Let's see.
Or maybe on the top.
I think, Sapna, if that's fine, I would recommend not, well, let's not focus on this at the moment. Maybe we can just give the floor to Andy, because we're actually showing your slides already so that you can go ahead and provide presentation. And in the meantime, we'll be trying to solve this technical issue.
Okay, the problem is I can't see the slides, so I can't see the slides that you're showing.
Yeah, I'm having, something's wrong with my network as well. It says I'm reading now, but I can't see anyone on the screen.
Is it possible you can point the camera at the slides so I can see them?
Okay, thank you. Whoever did that.
Okay, I think.
So yeah, if someone could just show me where the screen, and then I can see which slides you're showing.
They don't see what we're showing. He doesn't know what we're showing.
Refresh here. Connect with my
All right, Andy, I think.
Yeah.
So I have your front slide with me here, and maybe you can go through the presentation. Just tell me when to change, and if you show them on your own screen, it won't show. We won't be seeing it. I'm very sorry about this. We're trying to solve this, but it's not.
Okay, no problem, no problem. Right, thanks very much. So what I'm going to do is to give you a brief overview of the links between climate change and health, and conclude by reinforcing some of the messages you've already heard from Anneliese and Sapna about the importance of the healthcare system in mitigating and adapting to climate change. There have been a number of reports, and I won't go into them in detail, outlining the links between health and climate change, and two of them are shown in my first slide, coming from the Inter-Academy Partnership, a network of the world's science academies, that have recently published a global synthesis report and a number of regional reports on climate change, including in Africa, led by the network of African science academies. And it was a great privilege for me to chair the IEP Climate Change and Health Initiative. Could we move to the next slide, please? The next slide really focuses on where we are now. And I think many of you may have seen the most recent UNEP emissions gap report, but I think it's important to look at it again, because what it shows us is that if we look at current policies and if we look at the nationally determined contributions, we are very far away even from the 2 degree centigrade target, and even further, of course, from the 1.5 degree centigrade target, which is rapidly slipping out of our grasp. So at least 20 gigatons of carbon dioxide equivalent between even the more optimistic nationally determined contributions and where we need to be for the 1.5 degree target. So we have very few years of emissions left if we want to keep within those targets. So what would it look like? Can I have the next slide, please? What would the steps to a 1.5 degree world look like if we were to implement them? Well, these are summarized on this slide. Obviously, we need a sustained growth in renewables, and whilst we are seeing a growth in renewables, we're also seeing continuing exploitation of fossil fuels. We need to stop selling fossil fuel cars and emphasize the benefits of walking and cycling and public transport, engage aviation and shipping, ensure that all industrial installations are low carbon, stop deforestation, involve the agricultural and food sector in decreasing emissions and promoting healthy diets. And we need to retrofit existing buildings to make them much more energy efficient. Now, in doing so, we will not just reduce greenhouse gas emissions, we will also benefit health, and this has already been mentioned. But there are big near-term benefits from reduced air pollution, which causes millions of deaths a year, of course, improved diets, and of course greater physical activity as well from more active travel. So there's a lot of benefits in the near term, as well as reducing the risks of dangerous climate change. And then if we move on to the next slide, it just really reminds us that there are big inequalities in global carbon emissions. And the top 10% of emissions, many of us are included in that, are responsible for nearly half the world's individual carbon emissions. And of course, as we've already heard, the healthcare system, particularly in high-income countries, is an important contributor to that. And if the healthcare system was a country, it would be the 5th largest emitter in the world. So the healthcare system both has to adapt to climate change, but also reduce emissions. And the next slide just reminds us of the many pathways by which climate change can impact on human health. I'm not going to go into detail, but you can see that these increasing levels of greenhouse gases through a range of different exposure pathways affect a range of direct and less direct impacts on human health, including infectious diseases, food supply, water quality and quantity, air quality through wildfires, and of course increasing poverty, migration, and probably conflict as well. So moving to the next slide, it just reminds us that we have to create more resilient health systems that can help to withstand the climate shocks posed by climate change. And this will mean addressing all the building blocks of the health system, from financing to leadership, to workforce, to information systems, to essential products and supply chains, and to service delivery as well. So we need to engage all of these different building blocks of the health systems in creating more adaptive and resilient health systems can withstand the shocks coming from climate change. But more than that, as we've already heard and shown in the next slide, we also need to reduce the environmental footprint of the healthcare system. And today we're talking about greenhouse gas emissions, but of course there are other environmental impacts as well, like toxic chemicals and like fresh water use. And at COP26, over 50 countries committed to building health systems which are not just able to withstand the impacts of climate change, but are low carbon. And 14 countries set a deadline of 2050 or earlier by which their health systems will reach net zero. And since COP26, other health systems have joined that coalition. And if we look to the next slide, you can see the carbon footprint of the National Health Service in England, and you can see where those emissions come from. You can see that some of them, of course, do come from building energy, about 10%, but much of it comes from the medical equipment and the other supply chain issues, like pharmaceuticals, for example, which are all very energy intensive to produce. So in order to reduce the greenhouse gas emissions from the healthcare system, we need to not just decarbonize the energy supply and the transport system, but we also need to work with those industrial private sector corporations that are supplying the healthcare system with pharmaceuticals and medical equipment and ambulances and other vehicles, and support them in decarbonising their activities. And increasingly, NHS England has said that it will not be procuring pharmaceuticals and other medical equipment from suppliers that cannot deliver the decarbonisation within the next few years, to make at least make a commitment to decarbonising within a very short time. You can see from the right side of this slide that although many of the emissions are in the acute care sector, in hospitals, for example, primary care is also an important locus, because family doctors, and I used to be a family doctor, so I speak with some feeling about this, family doctors do control the production or the prescription of medicines, of pharmaceuticals. Many of those are within the control of the primary care services. So we need to act both through hospitals and primary care. And going to the next slide, I would say that there's an increasing range of educational resources. This is some of the educational resources available in the primary care sector through, for example, the Royal College of Family Doctors in the UK, the World Organization of Family Doctors Working Party on the Environment, and they are producing an increasing array of useful educational materials. So the final slide just reminds us really that we only have a small budget if we want to keep to 1.5 degrees. And this slide reminds us that we have less than 9 years of emissions left at current rates if we want to keep to 1.5 degrees centigrade, and less than 20 years of emissions left if we want to keep to 1.7 degrees. How we spend that remaining carbon budget, including how the healthcare system spends that budget, will be really an important issue for both health and equity. So I want to conclude by emphasizing the importance, not just of addressing the economy as a whole, but also emphasizing the leadership role that the healthcare sector can play in advancing progress towards a net zero and healthy economy. Thank you very much.
Thank you very much, Andy, for this very broad overview of this issue. So I will now give the floor to Gail, Director of Sustainability UCSF and UCSF Health, responsible for sustainability strategies and programs at the undergraduate health sciences research University of the 10 Campus University of California system.
All right, thank you, Anneliese. As Anneliese mentioned, I'm the Sustainability Director for UCSF and UC San Francisco Health. So consistent with the UC President, the Academic Senate, and students, each UC campus is creating a decarbonization strategy to combat climate change. And this definitely includes the 5 health systems within the UC system. And so we actually have existing sustainable practices policies that's been in existence since 2013. The first one is achieving a carbon neutrality for scopes 1 and 2 by 2025. And scope 1 is direct on-site emissions. We're talking about combustion of natural gas, fleet fuel, release of refrigerants and anesthesia gases into the atmosphere. And scope 2 are emissions from purchased electricity. The second target is carbon neutrality for scopes 1, 2, and 3 by 2050, and that includes 1 and 2 and scope 3, which is faculty, staff, student commuting, and institutionally funded air travel. We are working on expanding the other categories of scope 3 emissions as well. And then the third target is reducing our energy usage intensity, or total energy in kBTU per square foot, by 2% every year. And so we've been following Practice Green Health as members, which is a national leading membership and networking organization for the healthcare community. And they're making a substantial commitment to healthcare sustainability, specifically around carbon. We're using the Practice Green Health definitions, but UC Health has created targets to obtain 100% clean electricity by 2025. And we're also adopting energy performance targets specifically for acute care centers and medical office buildings. By maintaining our membership with Practice Green Health, we can benchmark against each other within the UC system, as well as other academic health systems across the country. One of the other areas is to achieve a target of 25 pounds of total waste per adjusted patient day, recognizing that if we are not sorting our waste properly and composting organics, that organics in landfills will generate methane gas that is released to the environment. In addition, by generating a lot of single-use materials, those types of materials are, in most cases, generated from fossil fuel, like polyester and polyethylene. So we're actually committing to purchasing more fossil fuel and supporting the fossil fuel industry by buying single-use disposables. And then reducing growth-adjusted potable water consumption by 36% from our 2020-25 for our baseline. And that effort really is to address the increased reliability of potable water and maintaining the quality and reducing our demand so that the communities around us can benefit from that. And lastly, procuring 30% sustainable food, as we're recognizing that sustainable food as defined by Practice Green Health really looks at organics and food that are grown locally so that there's less transportation emissions, in addition to having more organics that then don't use fossil fuel derived fertilizers or pesticides or herbicides on those foods. So in all these areas, it has a direct effect and impact on climate change. So in 2021, we issued a UC annual sustainability report, and the health system narrative included areas to address food insecurity in communities. University of California, Davis has been working on that in particular. These health systems also address the health impacts of climate change and have published impacts from wildfires through the UCSF magazine. And other research shows that climate change will give rise to more cancers, detrimental health effects for children, and links to diseases such as Alzheimer's. And all these are reported in the Climate Change and Cancer, the Lancet Oncology, and our website that Sapna provided a QR code for. And UC research also pointed out that greening health hospital operations can actually help combat climate change. And there's an article within UCSF Health magazine that discusses that. So our key strategies for UC decarbonization are threefold. Clean power, we should be buying clean power, not necessarily renewable, but carbon free. So that includes solar PV, solar thermal, wind, geothermal, hydropower, and nuclear. And we've been moving toward that direction through the UC's wholesale power program, or what we're calling UC Clean Power. The other strategy is building or renovating to fossil-free and energy-efficient buildings. So all new buildings, we're thoughtfully trying to incorporate energy efficiency and carbon-free design. And the next strategy is really trying to electrify and come up with an electrification plan for each campus and health system to transition completely away from natural gas in our buildings and our central power plants. And in fact, all 5 health systems have a central power plant, and that's the biggest challenge because we demand resilience and redundancy so that we can power our hospitals. So UC Health is actually really booming on green construction projects. UC Irvine, the new hospital, they're building an ambulatory center and advanced care buildings. They're all being designed to be all electric and carbon free. UC San Francisco is currently building an all-electric carbon-free surgery center and clinic that is being fueled 100% by City of San Francisco's hydropower system. And lastly, UC San Francisco is building a brand new replacement hospital, and it's seeking all-electric and carbon-free design, and that's currently being in discussion right now. UCSF is also leading other programs system-wide. We've been focusing on reducing emissions from inhaled anesthetics. So we've actually completely eliminated desflurane, which is a highly effective anesthesia gas that was invented at UC San Francisco. But the global warming potential of that anesthetic is 2,540, which is significant and high in comparison to the other anesthetic gases that we're using. And also we're looking at reducing the flow rate of the anesthesia gases to 0.7 liters per minute, and that is the most efficient rate, so there's no reason to use a higher rate during the maintenance phase if it's not necessary. We also are looking at reducing nitrous oxide, which has a global warming potential of 265, and the target is reducing our total usage by 5% in year 1. And then also exploring and how we can transition away from a centralized distribution system to local cylinders, because we're finding that there's significant leaks to the distribution system, which is so difficult to identify, that we felt we needed to just cap off the entire distribution piping system and use only local cylinders and through our anesthesia machines. Another program that we're looking at is really performing energy assessments and developing a multi-year plan for energy savings within the health systems, hospital buildings, and ORs in particular, which use 6 times more energy than is used on patient floors. We are working on an MRI energy study that will attempt to influence manufacturers to build more energy efficient imaging equipment, and we're working with US EPA to create an Energy Star rating for MRIs. And we're also working with ASHRAE to meter other medical equipment to see if we can find trending and find ways to influence the manufacturers to build more efficient equipment. And lastly, we're partnering with the city of San Francisco and other municipalities to try to bring electric ambulances to San Francisco so that we could and build charging stations within our hospital systems all within the city so that we could really try to influence driving down emissions from ambulances and idling. So, well, thank you very much, and I guess we'll take questions at the end. So thank you, Anneliese.
Many thanks, Gail, for this fantastic speech. I think we will perhaps listen first to Trish, otherwise we will really losing our audience, and then we will come back to you, Sheri. Is it okay for you? Okay.
Sure.
Thank you. So I will now give the floor to Trish Shazly, is a global health academic based at Heidelberg University, who specializes in climate change, migration and health. She's also affiliated with MSF, Doctor Without Borders, and the Climate Accelerator.
Okay, thank you. Thank you so much for the introduction. And thank you for staying. And I'd encourage you to approach us afterwards and ask any questions that you have and the reason why you've come to this particular session. So this is an implementation COP. And I think we need to speak less about problems and more about solutions, because that's what implementation is. So especially at this forum, where we're all very aware of the problem, and we don't need to convince anyone in the room that climate change is bad for health and that health systems need to change. And implementation means turning knowledge into action, and that's really the million-dollar question. How do we implement what we know? So we need to suggest, test, and also scale all of these solutions that we're talking about. One of these solutions is climate resilient and environmentally sustainable healthcare services. That's just one of the solutions though, because complex problems need multiple integrated solutions. So let's not think of it as a silver bullet. We also have to think about the social determinants of health before we think downstream at healthcare systems. But today I'd like to change this conversation a little bit to focus on the least developed countries and developing countries. So to date, the focus of this dossier internationally has been on big hospitals in high-income countries. If you do a search for climate resilient, environmentally sustainable hospitals, you'll definitely see the NHS pop up. And rightly so, because these are the hospitals that generate the most emissions. But we shouldn't forget that half of the world's population do not have access to essential health services. I'm going to say that again because I can hardly believe it. Half of the world's population does not have access to essential health services. And half of the healthcare facilities that we have don't have access to water and hygiene services. So imagine trying to deliver a baby without having water, flowing water. Imagine trying to do any kind of surgical procedure without being able to wash your hands or to offer a patient a toilet. That is the reality of the world that we're living in today. Also, 600 million people a year suffer catastrophic health costs due to out-of-pocket health costs. So paying for your caesarean section in Bangladesh is enough to bankrupt you and your family and generations coming after you. So the starting point for climate resilient development is not equal across countries. And I'm also here with the Médecins Sans Frontières, Doctors Without Borders, and we would like to bring more attention to this issue, that people don't have access to healthcare at all. So in that way, discussion about climate resilient, environmentally sustainable health systems can't be separated from other discussions about universal healthcare and health system strengthening. Remembering that very little climate finance goes to the least developed countries and it isn't being invested in health. So if you go to the next slide, I'm not going to focus on the problem too much, but just to say that climate change, as we know, poses a huge threat to health. In all of these different pathways, leading to increasing deaths and injuries from extreme weather events, changing patterns of infectious diseases, waterborne diseases, food safety, and also migration and conflict. So there's a double challenge being posed to health systems. First, we've got this increased burden of disease, and then we've also been challenged to reduce our emissions. Remembering that the healthcare system globally produces about 6% of emissions, and Africa as a continent produces less than 4% of emissions. So if we can remove the emissions from the health sector that are primarily generated from high-income countries, we could do the equivalent of removing the contribution of an entire continent. So we've heard enough about the problems. We have to talk about solutions. So we've never had this much knowledge about climate change and health. It is a field that has been developed for 30 years. We also have the tools. We also have the tools to decarbonise our economies, our societies, and our health systems. And arguably, and I hope by the end of COP27 this will still be the case, we have never had more political commitment. So we have an implementation problem. It's what we call in science the 17-year odyssey. It actually takes, in public health and medicine, 17 years for an idea, a novel idea, to be mainstreamed into practice. And that is simply no longer acceptable. So climate resilient health systems, this is part of the solution. They are systems that can anticipate, prepare for, and respond and recover to climate-related shocks and stresses. But let's not pretend this is a brand new idea. It is a little bit of an old wine in a new bottle, because we have been talking about health systems resilience for a long time. And if you think about a health system that's resilient to climate change, it should also be resilient to conflict and epidemics, etc., which has especially been brought into our attention since COVID. So there's this strategy, if we're getting into the solution, is built on the 6 building blocks of a health system. And I'm just going to give you a couple of concrete examples so that it feels a bit more tangible. A climate resilient health system has health programs that are climate informed. So you can use meteorological forecasts into the health systems to prepare for peaks of climate sensitive diseases. It has a health workforce that is sufficient, supported, aware and capacitated. And there's been a lot of discussion about training doctors, but the vast majority of healthcare worldwide is actually delivered by nurses, especially in developing countries, and there are 3 times as many nurses as there are doctors. So if you really want to mobilise this type of activity, then you need to engage nurses. And then also to say that in terms of the health workforce, sure, you can teach them about climate change, that helps. But first we have to make sure that we have enough nurses and doctors to look after patients. Because one example, in Chad, Chad has 35 nurses and doctors per 100,000 people in the population, and the UK has 340 So they have 10 times as many nurses and doctors. So you can imagine the stress that the people working in Chad are under and will continue to be working under when climate change increases malnutrition and increases the burden of disease. And if we move to the next slide, the next part of the solution is, I just wanted to add one more of solution, which is integrated early warning systems. This is another way to build climate resilient health systems. The UN has pledged to cover everyone on Earth with early warning systems in the next 5 years, which is a huge pledge, but that needs to be connected to actual responses. So there's no point telling people working in Chad that are already stretched that it's going to get a lot worse unless you actually help them respond to that challenge. And the next part, we might just skip this, we might just go to environmentally sustainable health systems. So just to give you a couple of concrete examples, environmentally sustainable health systems have wash and waste systems that are sustainable and safe. They have energy systems that are reliable, affordable and not polluting, and they have a supply chain that is appropriate, efficient, and that it remains accessible and functional during disasters. And that's the real breaking point. It needs to function in disasters. And just the final slide, I think. So just to give an example of what we're doing in terms of implementation, I'm working at the moment with an organisation called the Climate Action Accelerator and a medical humanitarian organisation called Alima, and we're working in Chad to build a climate resilient hospital as a pilot project. And if proof of concept works out, we hope to scale this in other countries in Africa. These are the priorities that the team that we've just visited in Chad would like to address. Firstly, the climate hazards that they're most concerned about are extreme heat, droughts, floods and water scarcity. And their prioritised needs are around building and infrastructure. They currently have a tent outside when they have peaks of malnutrition, and they have 400% capacity, as in 4 times as many patients as they can house. There's overflow into this tent, and nobody goes in there because it's 60 degrees. So obviously that needs a solution. They want to build their health workforce, and they want to integrate meteorological data into health programming so that they know when they're going to get peaks of malaria and meningitis and malnutrition in particular. And final slide. So I'll just leave you with this image of a health facility falling into the Padma River in Bangladesh. It also reminds me of when I visited the Solomon Islands at the Honiara Tertiary Referral Hospital. The beach in front of it has eroded so much that sea spray is coming through the windows into the paediatric ward. So climate change is affecting the health infrastructure, but we also need to remember that health systems are about people. So the actions that we take also have to address people, because they're the people that are going to implement the change and sustain the change. So we need to get to work, as Barack Obama always says, and operationalise our ambitions, measure our success and failures, and communicate and scale these solutions across the board. Thank you very much.
Thank you very much, Trish. We will now listen to you, Sheri. Sheri Weiser is Professor of Medicine and Internist at UC San Francisco's Division of HIV, Infectious Disease and Global Medicine at Zuckerberg San Francisco General Hospital. She is founding co-director of University of California, the University of California, the Center for Climate, Health and Equity.
Thank you so much, Anneliese, and I wish I could be there with all of you. I'm going to be speaking about our new center, as well as how to activate the healthcare sector into climate action for a healthier and more equitable world. Next slide. So as we've heard today, without urgent and immediate action, climate change is going to profoundly affect all aspects of health at every stage of life, from birth through old age. So this is really an all hands on deck moment to secure a healthy future for all. Next slide. So we know that climate change intersects with other social determinants of health to amplify injustice, as we just heard, and further drive disparities. So climate change impacts, as we know, are not distributed equally. Those worldwide who have contributed least to climate change suffer first and worst from its negative health impacts. So as noted by the recent Lancet Countdown report, a health and health equity-centered response is needed to address this crisis. Next slide. And the health sector really is in a unique position to advance climate action. So first of all, health professionals are already on the front lines of climate change, treating patients in affected communities who have climate-related illnesses and injuries. Also, the ties that health professionals and the healthcare sector have to affected communities can make them strong community anchors for building climate and health resilience. Also, in view of our large carbon footprint that we've been speaking about, it's long overdue that the healthcare sector transforms itself from a climate contributor to a climate steward. And this is particularly the case in view of the oath that we as health professionals took to first do no harm. Next slide. So towards that end, in July of 2021, we launched the University of California Center for Climate Health and Equity with a mission to really harness that expertise and leadership of the healthcare sector to drive ambitious climate action for health and health action for the climate. And we're doing this through 4 streams of work: research, education, health system sustainability and policy, as well as through cross-cutting initiatives like our UC-wide Climate and Mental Health Council. Our vision is to advance equitable and just climate solutions that promote human health and a healthy planet. Next slide. So we're based at the University of California, San Francisco, but we really span all 10 UC campuses and 5 health systems with over 100 faculty affiliates, as well as many students and staff. So our approach includes leveraging that expertise, resources, and innovation of the UC system, centering community perspectives and needs through an equity and justice lens that we really are bringing to all of our work, collaborating across civil society and government to amplify our synergies, and then finally implementing a needs-driven and policy-responsive agenda to yield tangible and rapid public health benefits in California and beyond. Next. So our impact has really been in 4 major areas that you can see here: in research, education, healthcare, sustainability, and community building. And I'm going to be going into these impacts in the next few slides. So next. So we're leveraging the power of education, as we've been talking about today, to drive change with a goal to build a world-class education hub on climate and health. So just as some examples, last year we launched a course on climate and health justice at UCSF, where students then submitted op-ed pieces and YouTube videos to really maximize and amplify their impacts. And we have plans to expand this course across the UC system. We also created, just for example, some patient care materials related to the health impacts of wildfires, which are now housed in an online education hub. And materials are available in English, Spanish, and Mandarin, both on the general health impacts of wildfires, as well as specific impacts, for instance, on lung, heart, pregnancy, skin, mental health, and children's health. So this year, we're going to be launching a student ambassadorship program for climate and health education, where we're going to be supporting faculty and student pairs to develop climate and health content to integrate across all of our health professional schools. And we also, I think, have several exciting courses under development. For instance, a paramedicine course to help train first responders to address climate health emergencies, and also a new course on climate and mental health resilience under development, where we're going to be helping students engage in climate activism as a way to address their own eco-anxiety. Next. So we're generating missing link research that's actionable and responsive to community needs. So last year, we launched a UC-wide seed grant program, which funded projects on topics such as climate resilience among vulnerable communities in the Central Valley of California, and also among indigenous communities in Guatemala, pilot interventions related to wildfire smoke and extreme heat in California, and urban forest equity in Los Angeles. And we're now working on a climate, health, and equity data dashboard for California, which will be able to be accessed by our faculty, students, staff, as well as our community partners, with a goal to use these data to directly inform policy and programs. Next year, we're going to be hosting a series of 3 regional workshops, so in 3 different regions of California, where we're going to bring together UC researchers, public health agencies, policymakers, and community partners to help shape research priorities. And this is going to culminate in the launch of a number of community-actioned research partnerships where we're going to be piloting equity-driven solutions that really center community priorities. Next slide. So we're accelerating pathways, as we've heard from Gail, towards a climate-resilient health sector by greening our health systems and also ensuring that both our public health infrastructure and our clinical systems are prepared for acute and long-term climate threats. So towards this end, you've already been hearing about some of the critical work across the UC system to reduce emissions from our clinical practices. For example, the work that we've done with anesthetic gas uses, with changing how we're using anesthetic gases, which leads not only to reduced carbon emissions, but also to cost savings. This year, we're going to be launching a clinical sustainability fellowship, which is the first of its kind in the United States, that's going to be supporting and mentoring faculty-led decarbonization projects across the UC system. And finally, we are developing plans for clinical climate emergency response teams that are going to be activated in the times of acute climate health threats. And we're going to be piloting this both in the Bay Area and in the Central Valley of California in partnerships with our local public health departments and community health providers. Next slide. So just as an example of our decarbonization work, radiology faculty started the UC Green Radiology Initiative with a goal to decrease radiology's impact on the environment. And you can see the 4 pillars of this initiative listed here, which includes, for example, assessing the carbon emissions for specific imaging modalities and really educating health providers on how to take energy considerations into consideration when ordering radiology studies. Next slide. And finally, we are working to create a climate and health community of practice by convening and supporting faculty, staff, and students from all 10 UC campuses. Towards that end, we now have 8 current climate health and equity student fellows from 6 different campuses this year. We have faculty, campus and pillar leads from all 10 campuses, and our collaborations are harnessing the expertise of the entire UC system. Next slide. So I'd like to invite everyone to visit our website, to connect with us, learn more about what we're doing, and you will also find recordings from our virtual launch event held last May, where we featured health leaders from across the United States. And then just the last slide, and I'll just end by saying that action on climate change is the greatest global health opportunity of this century. We look forward to collaborating with many of the health systems presented here to meet this formidable challenge. And I will stop there, and thank you very much.
Thank you very much, Sheri, for this very interesting speech and presentation. So it's now my pleasure to give the floor to Charlotte Halpern. She's a researcher at the Centre for European Studies and Comparative Politics at Sciences Po. And she's also a member of the Center of the Earth Politics. Thank you.
Thank you, Anneliese, and I will just stand here, so I'm afraid you won't be able to see me on screen, but it's easier to pass the slides and actually speak from here. All right, so I'm going to speak about how to promote some cross-sectoral collaboration to deliver on zero carbon, and interestingly, this builds on what Andy Haines has been presenting earlier on, because we are also interested in NHS England and the way through which they've been developing a carbon footprint. So why should we focus on cross-sectoral linkages? My own background in the policy community I come from is not health. I come from more of the transport, mobility sector. What I'm interested in when I think about health is how transport and trip-generating sectors often share some high-level targets, in this case, achieving net zero carbon. But there are many practical differences in order to achieve such a goal. First, how is carbon measures varies from one sector to the other. The dates at which targets is to be achieved also change from one sector to the other. Notions of success, for example, is fleet electrification enough, is also something that varies from one sector to the other, and there also are different funding priorities. So when we want to try to achieve all those cross-sectoral linkages, for example, that the NHS is trying to deliver on by 2045, that it raises the question of cross-sectoral collaborations, and this is exactly, thank you putting the camera on myself. This is exactly what we're doing as part of the Civitas Samplus project, which is a consortium which is led by the city of Antwerp in Belgium, in Flanders, together with some 15 partners in Europe. And we've been working as part of a laboratory, city laboratory, in which we're testing these ideas. So what are we interested in? What we want to look at with my colleagues is to try to understand how to achieve those transition pathways. So if we want to think about the vision, which is about a zero carbon future city, then we need to backcast and think about what is needed to be achieved in order to reach for this goal. As part of this, you would need to develop a number of policies and measures in the context of mobility. So you would probably think about what could be achieved in terms of active mobility or changing your vehicle fleet. But we can also think about new carbon reservoirs, new carbon emission reduction reservoirs, such as linking together with health or with education or with any other trip-generating sector which would then need to be on board. So long-term planning requires new funding, new governance, and new partnership model, and this is what we're trying to develop. So my colleague Peter Jones from UCL, the Center for Transport Studies, have been working together with some of our colleagues from Vectos in order to think about what are the weak links if we want to think about how to reduce travel in the health sector, for example. And what he proposes is not just to look at what we could improve, for example, decarbonization of vehicle fleet. We know what we can shift by supporting or encouraging the shift to sustainable modes, and this is already what governments and transport providers or major trip attractors are doing. But we can also think about what measures could be avoided in order to generate new trips. And this is where we can think about cross-sectoral collaboration with education, with health, also with leisure, with retail, in order to avoid, for example, some physical meetings. This is part of what we're doing today. We have a hybrid event, so some of the trips have been avoided. We're also thinking about providing equipment at home, and this is something that has been developed during the COVID crisis quite extensively. But we can also think about where to locate facility provision in the city, in the region. And this is where collaborating with the city and having a place-based strategy to develop and achieve those goals may come into relevance. And this is what we're trying to do. So as part of what Andy Haines has been presenting before, we're also looking at the delivery of a net zero national health service in the UK, where we are focusing exactly on what is referred to as the NHS Carbon Footprint Plus. So on the left side of this graph, you would find scope 1 and 2, so basically what the NHS directly controls in terms of its emissions. But what we're focusing on is not just scope 3, so what the NHS emissions profile is not directly controlled by it, but also travel, which largely falls outside this scope. So we're trying to focus on this transversal issue of travel, which addresses measures that are within scope 1 and 2, within scope 3, but also within what is called NHS Carbon Footprint Plus. And this is what we're doing as part of SunPlus. In order to do that, we're working together with the city region of Greater Manchester in the north of England, where a priority has been set on travel, transport, and quality. And in order to do this, a number of actions have been listed in order to avoid those travels in the future. Those actions fall under providing better air quality. They also have to do together with developing a local health transport system, system, similarly to what Trish has been explaining before, that is more integrated, in which we bring different actors around the table, but more generally to think about all the different boroughs within Greater Manchester where this approach could be developed in order to identify, but also to avoid and act upon those travels that could be avoided in the health sector. So it's very much something that has been developed as part of the Manchester City Lab in the Civitas SunPlus to establish those effective cross-sector links between the health and transport sector and for joined-up decarbonization policy. So this might sound a little bit abstract, a little bit abstract to you, but I'm just going to give you 3 examples of those concrete actions we've been addressing as part of the project. The first one has been led on by my colleague Stuart Blackadder, who is working with Transport for Greater Manchester and leading on this City Lab, what he's been doing is to provide and develop an evidence-based for where are those trips within the health sector that could be avoided. And what he identified as part of his work is first that most carbon integration between health and transport mostly happen around active travel. So for example, supporting walking and cycling as being one of the measures that are being addressed by a number of cities across the world. There also were some stronger ties that have been developed during COVID. So for example, in the case of Manchester, it's the program which is called Nightingale Hospital. There were some bike loans, but also some Metrolink offer for NHS staff, and especially the health staff throughout the city who wanted to travel more easily to the hospital in order to continue with their duty during COVID. So they could identify a number of opportunities for digital services to lead to decarbonization. However, what was identified as part of the project also are examples of more in-depth collaborations that have been developed within the health sector but have not been scaled up at the city region so far. And in this sense, the City Lab provides an opportunity to first identify those opportunities, but then to support the scaling up. So one example is the fact that there has been some community diagnostic center in Oldham, which is one district of Greater Manchester, using some of Transport for Greater Manchester modeling in order to reduce travel to primary healthcare facilities. There also is a pilot program for macular degeneration, which is located in 3 different local stations in Greater Manchester. And here it has been followed, but not with direct collaboration with transport sector. And the last one we could identify is the reorganization of customer locations within the Wigan district, in which before reorganization on the left-hand side of my screen, you can see that all those locations were completely spread out throughout the region, and after the reorganization, they're much more concentrated and reorganized in order to reduce the number of travels and number of trips in order to arrive on location. So this is one of the activities that we've been trying to focus on, and which Stuart has been leading on, has been to produce this evidence base to actually know what could be achieved at the city region level. The second action he's been working on has been to develop a short-term action plan, which has been co-created with the health sector from 2023 to 2026, in which we could really focus on those activities that could be achieved together in order to further reduce travels in the city region. And part of this has to do with the volume of travel. So for example, remote communication or in-home service provision and home deliveries of medications, for example, or of service. But we can also think about health-related visits to homes. He's also been trying to focus on localization of health facilities. So those are the measures that the Transport for Greater Manchester is currently being exploring together with the health sector. The final action I'd like to report on, and this will be the last one, this is the one I've been focusing on as part of my work in SUMPLUS, has to do with governance. Because when we think about aligning those 2 sectors, we all think this is very easy and very easily done. But as a matter of fact, we all know that policies and policy strategies are very much disconnected from one another. We're talking about 2 different silos in policy and in governance. So part of my work in SUMPLUS has been to identify some of the policy linkages, but also to think about how to establish a joint venue in order to collectively work on how to deliver on those goals. And in order to do that, we first thought about how to build ownership and responsibility. So to get internally in those organizations, the senior politicians, those that would never think about those cross-sectoral linkages, but also to reach out to senior and higher civil servants in both sectors in order to bring them around the table together with the professional community, the doctors, the nurses, but also the patients and the wider public, to think about how to work together and deliver on these actions. We also try to think about aligning priorities, and when we think about aligning priorities, again, this may be a little bit of a jargon for those of you who are not familiar with public policy making and decision making, but when we think about it in very concrete terms, it means that in Greater Manchester, as in most cities around the world, I would believe, there is a strong disconnect in terms of budgets, in terms of timelines, in terms of leveraging opportunities together. So some of the work that we've been doing has been to work together with Transport for Greater Manchester, with Stuart Blackadder, in order to develop the short-term action plan. We've been working with the Greater Manchester Combined Authority in order to bring all joint policy themes, not just health, but also education, also tourism. We have other sectors relevant for long-term strategies in Greater Manchester, and finally to work together with the Integrated Care Partnership in order to deliver on the Green Plan and the objectives that have been set by the NHS. And this is my very final slide. What we hope to achieve with this, as you understand, is to start to think about cross-sectoral linkages in health, but also to move on and to include other sectors in this thinking in order to identify all those carbon emission reduction reservoirs that we can think of by bringing together those different sectors, by starting a conversation between them, and not just thinking in terms of the measures they can deliver on, the knowledge they need in order to do so, but also to set up the right policy venues within which these goals are achievable. So with this, thank you very much, and I will stop here and give the floor to our next colleague. Thanks a lot.
Thank you very much, Charlotte. So I will now give the floor to the Professor Rainer Sauerborn, just coming in time, is Professor of Climate Change and Health at the Heidelberg University.
Now it's on. So sorry to be late. I had to give a presentation in another panel, and before us was the German Secretary of State, Minister of Foreign Affairs, and so the whole thing got pushed a little bit down the road. So sorry for that. And I'm very glad to see so many people from Africa and other countries in the Global South. I just had a talk with a gentleman from Burkina Faso, who works on climate-resilient healthcare systems. So it's not a privilege of the North to think about these things. And they were looking at better constructions with more traditional, like adobe with a little bit of cement and so forth. So now we are talking. And do you have a pointer? No? Yeah. No, I can do it. And to move it, first of all, to make it full is here, right? Oh, you see it full. Okay. Everything is fine. Sorry for the delay. So thank you for inviting me, Anneliese, and thanks for also the panel, dear co-panelists, dear audience. So I'm talking about what can we do in a university hospital to reduce our emissions? You know that the health sector has 6 to 7% of all our emissions in Germany, and worldwide it's 4%, which is double the air travel. So, but nobody talks about it. It's because we are doing good, we are saving lives, but that's not an excuse, because you can save lives with much less CO2. Maybe I should put this up here. And there we go. So I will tell you what Scope 3 emissions are. Every enterprise in the world must measure, or in certain countries, must measure their carbon footprint. And there are 3 scopes, and I will explain what this is, 3 categories of emissions. And we are focusing on this Scope 3 emissions for a reason, and I will tell you why. Yeah. Now you have the Scope 1, Scope 2, Scope 3, and every line. And in the first line you have what it is. So Scope 1 is mainly energy and heating. And when I first got into this topic, I thought, what's the carbon footprint of a hospital? Oh, it's air conditioning, heating, energy. You will see that this is dead wrong. It's not. Scope 2 is purchased electricity, yeah? And Scope 3 is mainly the supply chain. You see here, the third to the right, supply chain. And staff commute, some little things, but it's mainly supply chain, and here we talk about drugs, and you will see that drugs have a major contribution to the footprint of our hospital, as of the NHS in Britain, as of any other hospital in the global north. Unfortunately, this kind of study, to my knowledge, has never done in the global south. Let's say in Sri Lanka, the University Hospital of Colombo had expressed some interest, but if you want to know what a big teaching hospital in your country emits, then let's talk. So you see under supply chain, you have pharmaceuticals and chemicals, medical equipment, medical supplies, gloves, syringes and the rest of it, and food and catering, interesting. So everything that you need to do to deliver healthcare is basically in the scope 3. Energy, heating, and personnel travel is in scope in the other rubric. Yeah. Okay. So now we know what scope 3 is and why we focus on it, and you will see why in a second. So, and we focus on this. I just told you we focus on the supply chain, which is the scope 3. Good. And here is the NHS. I must say, I throw flowers to our British colleagues. It's easy for them because they have this unified health system, the NHS, the National Health Service. And you see in the colors, the same colors, you couldn't see them very well, or I couldn't see them on the screen, but you see the colors very well. The purple is the scope 1, the green and yellow, the green is the scope 2, the yellow is additional other little things, and the big blue is the scope 3. So in the National Health System Service of the United Kingdom, you see that it is the largest portion in their emission reduction path, as it is the large proportion in their footprint, logically. So, and I wish I could show such a graph for our university hospital, or for Germany at large, where you see the black line that goes until what, 2020. The report is from 2020, and then it shows you can't, some of the things you cannot reduce, and others you must reduce, and the biggest lump is, again, supplies scope 3 emissions. So that's why we started a project focusing on this. Oops, now we're good. So here's what we did. Our objective was save 7% of the annual scope 3 emission for the next 3 years. And how did we do this? This is a timeline. First of all, we had a company who was good at calculating the emissions from everything they did in scope 3. So every drug, every supply, every food that they offered, they could tell us how much of carbon equivalent is in there. The second thing is, if you cannot just say, okay, now we take the biggest portion, because you need to bring people on board. If the doctors hear that you want to reduce the use of some drugs, they will go at your throat. They will say, I am the doctor, and who are you to tell me what to do? So you need to have everybody on board, and we have very good social engineering to have these stakeholder meetings. And once then a list is made of the biggest polluters or emitters and of those who people accept to reduce, then we go into the implementation, and what you may or may not be able to read, yes you can, it is evaluating the whole thing. It's a 3-year project, and in the end we want to reduce by 6,000 tons of CO2 every year. But we are not only measuring the CO2 mitigation, but we are measuring the costs, the savings, the costs, and what is a little bit innovative, the health co-benefits. For those of you who don't know that term, is if you want to do something good for the climate that's also good for your health or for some other thing, you have a co-benefit, double dividend, as the Americans say, okay? So if I use my bike instead of going with my car, I save the planet, if you like, and I also save my own health. I lose weight and I'm fit, hopefully. Well, these are two approaches. Maybe it's a little bit too, maybe if you are interested, we can delve into this in the discussion. It's not so easy, as I just said, to measure the footprint of each of the components and each drug and so forth. The wholesale approach is you look at the turnover, and then for Germany there's a certain conversion from economic activity to carbon emissions, which is very approximate, I must say, but that's what all of them do, including the NHS. We want to go then for those interventions that we agree on with the stakeholders. We want to go the sort of bottom-up approach, which looks at really each drug and each let's say, gloves, what is in it, what are the production methods, and how much CO2 is emitted during the process. Okay, that's a technical thing. And here are some results. Our Heidelberg carbon footprint looks very much like or resembles the one in the NHS. You see the blue stuff, same color code, is again scope 3. So our assumption was right that these things that nobody thinks are contributed to hospital emissions, major contributors, do dominate the scene. Everything's fine? Yeah, okay. And now here's the process. So we started from left to right with a literature search. What do others, what have they found? And lo and behold, there's not much many studies have been done on this. And we picked from the literature some low-hanging fruit, if you like, which we wanted to then bring into, on the top right, our stakeholder meetings. If you just go there and say, oh, what do you like to reduce? They ask what have others done and what is successful and has been tested. So some small gains are use less of anesthetic gases. There are less and more climate-friendly gases, and you can use a more climate-friendly gas. Use fewer and different pharmaceuticals. That is, in England, that's about 1/3 of the carbon footprint of the NHS is drugs. Unbelievable, but it's true. And we wanted to pick one drug, which is, or group of drugs, which is antibiotics. And antibiotics have the nice side effect: if you reduce their use in a diligent way, you can reduce adverse effects, and you can thus generate health co-benefits. Support active and electric mobility is not strictly a scope 3 thing, but it's a low-hanging fruit, so we grabbed it. And it generates a co-benefit, of course, no explanation needed. And purchase less or different medical products. As I said, they are, with the drugs, the largest portion of the footprint. And the final thing is serve a planetary health diet, which is basically plant-based and thus emits less and has health co-benefits. Because if you don't eat meat, particularly red meat, then you are staying more healthy, you avoid cancer and the rest of it. So again, we are not only looking at CO2, we are looking at CO2 plus resources, finances, plus health co-benefits. And that is, in a way, innovative. And you see how all this goes into a funnel. The first ball in the funnel is acceptability. It's so important, because if you don't have acceptance and if you don't bring people on board, it won't work. They will obstruct it in 1,000 ways. And then we project, based on our consensus, an expected global greenhouse gas reduction, and then we will calculate the expected health co-benefits and the savings or the costs that takes. And here is what the acceptability, I cannot overstress this, requires. We have monthly meeting with the head of the hospital. It's a huge hospital, but they understand that this is important. So here are some first numbers. The cost, we only know for the moment whether they go up or down. The CO2 we have calculated, and the health, it's very difficult, but we are on it, but we suggest that they all go up, that they all have positive co-benefits. So here are our three in the rows, our three priority areas where we start with. That doesn't mean that this is all. And you see that they have much different CO2 savings, and in the end, this has just started the project a year ago, and it's a 3-year project. We will fill all these cells with numbers, and hopefully on the next COP we can report to you the results. And here are some subtasks: support active mobility. No, that's well, we can skip this to save time. And we use also intervention trials, randomized controlled trials. We distribute the same number of canteen meals to consenting the staff and tell them, would you like to have a normal diet? You see the bottom one, there's a control with German sausage and all the rest of it. And then there's the intervention diet, which is the planetary diet, which is completely plant-based, and then we have an implementation phase, and then we look at outcomes, nutrition and health, climate and environment, and then we will have a really good proof that all our medical colleagues hopefully accept, because they are eager to see randomized controlled trials. And that is already my talk. This is Heidelberg, and unfortunately you don't see the beautiful part very well, which is in the back where the river flows. You see a red roof, little line there. That's the old city, and the campus and the hospitals is just in front of you. So come visit and join with us, maybe in your country, to implement a similar thing. And thank you very much for your attention. I'm looking forward for the discussion.
Thank you so much, Rainer. It's very inspiring always to listen to you. So I think we have no windows to questions. Unfortunately, I will just say a few words and then give the last one to Sapna. And I will ask to all the virtual speakers to open the camera so that Andy, if you agree, so then we will do a final picture. So thanks to all panelists for these fantastic insights. Very often we hear the argument that the health sector is too crucial to care about the greenhouse gas emission. That is not the priority, or that it could compromise the quality of care. We heard today compelling views that showed this wasn't the case, and how it could be done. Everyone needs to do one's share, and health is a powerful leverage for climate action. So this is the raison d'être of the Global Alliance for Planetary Health, and I encourage you all to follow also this work. So thank you very much, and Sapna, I will give you the last word.
I will just echo what you said, Anneliese. Thank you all for joining the panel. I wish we could be there with you in person. It was very interesting and inspiring to hear what folks around the world are thinking about and are doing with regard to health and climate change and hospital operations. I appreciated hearing from everyone. Thank you.
Thank you so much. Okay. We will now, so please, Andy, Sapna, we will do a final picture, perhaps.